Good morning, good afternoon, good evening to all of you watching and joining in on the webinar today. I really appreciate your time, whether you are here joining us live, going to join us in a few minutes, catch the end, watch this later on. I cannot say what it means to me for people to sacrifice their time each week, each weekend, to listen to what I have to say or ramble a little bit about pain and communication, which has really become a big passion of mine and something that I'm reminded of still needs work day in and day out that I'm in the clinic. So my hope for today is pretty simple. I just want to make a few ideas apparent for all of you, stress the importance of communication and potentially therapeutic alliance. How can we describe or educate some very complex topics in a very simple way? And that might open up the avenue for trust. I've done this lecture before, and I think that a couple of new things have emerged in my mind, both recently and over the last year, on how I can do this a little bit better, and basically built off of the feedback I've gotten from you guys. So if there is feedback from today, good, bad, indifferent, I would encourage you to reach out and let me know what you enjoyed, what maybe you want to challenge, and what you would love to see more of. My hope is to take this course, break it up into different body parts so we can view a communication pain BPS style through the foot and the ankle, through the low back, through the shoulder, through whatever you guys sort of want to learn a little bit more of. So the way that you guys can help me is by just giving me feedback, which I would really, really appreciate. You won't need a lot of tools for today. As we keep going, one of the things that you might realize is, where's the words? There aren't any really words on our presentation today because I want us to really get involved with the story. I want us to get involved with listening. So other than a pen and paper, which I would encourage you to try to use as little as possible, just try to spend time listening. Highlight questions that come to your mind specifically. Consider where you would want to go to learn a little bit more about those questions that pop up today after our webinar. This will only be about 45 minutes, so I'm not going to be able to answer every question that pops up. Hopefully I can answer a few, but I really want you guys to think, what are you going to do with the questions that you're left with after today? And of course, we can always help each other out on that. As always, with most of the presentations I give, I have an outline, but I don't typically know where I'm always going. I try not to make it boring for both you and I, but that's about the only promise I can make, is that I really try to make this stuff a little bit more interesting, a little bit more engaging, because I think the biggest thing that tunes me out about soft skills is that they're often presented in a very boring or maybe even straightforward manner. And I think they're just as complicated or complex as exercise progressions and regressions, systemizing assessments, knowing how to lateralize different activities, knowing exercise prescription. Well, what about education prescription? What about communication prescription? How long does it take to actually form an alliance with people? These are the things that we also have to keep in mind. I share this picture, which probably needs to be updated by now. I have a couple of other ones, but for some reason, I just really enjoy this one because it just speaks to our relationship on how these two little girls kind of shape who we are as a couple. And this is my fiance, Courtney Conley. My daughter, coming in the middle of us, as she loves to do, is Avery, right there on the bottom of your screen. And to the right, with the beautiful blonde curly hair, is Addison. Now, I don't go off on long tangents anymore about who I am and what I've done, because I think that also is boring. But I show a picture of my internal world, or the people who really shape me now, because these are my biases. My biases are shaped by everyone in this picture, by being a dad to a girl, by being a stepdad to a girl, by being in a relationship, by being in a long distance relationship. My fiance is also a chiropractor, so she helps me see this world that we're all in through a different lens. I'm trained as a physical therapist. I don't know if there's a traditional lens that we all share now in any profession. So we really need to kind of understand or question what makes us different as providers. So if you are a physical therapist, if you're a yoga instructor, if you're a massage therapist, if you're a strength coach, the question I want you to think about right now is what makes me different from everyone else? And the way that I've sort of started to think about physical therapy is that in the physical therapy realm, I believe collectively, this is not speaking for everyone, that through a physical therapy light, we should be as a profession taking in more consideration for psychosocial factors. And I think that's what makes us different than chiropractors or manual therapists or massage-based therapists who may see the lens a little bit more descriptive or a little bit more focused through a biomechanical scenario. So if we blend these worlds, if we blend these lenses on how to view the world, I think the picture of not only the person we're trying to help, but the environment in which they're in becomes a lot clearer. So these are my biases. What are yours? What shapes your beliefs? Is it your friends? Is it your family? Is it your clients? How do you know you're successful in what we do? And I think that's a very important question to reflect on. Because if you ask Courtney, as a chiropractor, what makes her successful? She'll say taking the lens of a biomechanical model and understanding the ins and outs to help people out of pain. If you ask me, I'm going to tell you understanding people's emotions, their resources, their environments, and their beliefs help me a lot more than just maybe assessing pure movement right now. So what shapes your lens? How did you come to those beliefs? Are you sure about those beliefs? There's an experiment done on pigeons where if you leave a pigeon in a box and its ability to hit numbers or sequences over and over again, you can program the pigeon to actually figure out a sequence that will release food. So let's say it's yellow, 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 red, blue, and there's 3 options. And the pigeon will actually learn yellow, 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 red, blue releases food. So what do you think the pigeon gets really good at? Yellow, 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 red, blue. Now, here's the thing. Even when you switch the pattern and start having the food come out randomly, the pigeon will still do yellow, 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 red, blue, yellow, 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 red, blue. And when I read this study or I was introduced to that story, I thought about myself as a professional. I was successful one time. I was successful with this one client. I was successful taking this one course. And that's what I kept doing over and over and over again because I had that good outcome one time. So now I base everything I do on that previous 1 or 2 good outcomes rather than taking a clean slate with every single person that comes into the clinic, which is what I try to do now since I realized that maybe I was making that mistake before. So I'm not saying that having a system is not important. We need a system. We need a foundational way of looking at people. But from there, or every single time we meet someone, having the previous experience of the person before us influence the person in front of us maybe is not the best idea. And if we want to think about that one more different way before continuing, if you and me were going to Vegas and we were playing roulette, every single time we play roulette, there's an equal chance of the same outcome. The roulette board doesn't change. There's only one marble or thing that flows around. Sorry, I don't gamble a lot, so I don't know the all actual names. But if we're playing roulette, the odds change or the odds stay the same every single time. So just because red 18 came up with the previous roll, red 18 can still come up again equally the next time, but so can every other outcome. So when I now think of care, I'm trying to look at the big pieces of the roulette board. Are there bigger squares? Are there bigger slices that I can invest in first and foremost with every client that will give me the best chance to succeed? And then realize all the other potential outcomes that are likely or possible, not only in one session, but every single session. So now that brings us to the question of who are you, right? Who are you joining us today? Are you a PT? Are you a massage therapist? Are you a chiropractor? Are you a dad? Are you a fiance, spouse, partner, business owner, coworker, right? There's so many things that make us who we are. I think that the biggest question, or maybe the biggest idea that my clients in persistent pain struggle with is not who they are, but it's what they are. And that what question is what is happening to them in the present moment. The who's are usually based on our past. I went to school and now I'm a physical therapist. I'm in a relationship, now I'm a fiance. I had my daughter 9 years ago. I'm a dad. So the who questions sort of keep us focused into a timeline that already happened. The what questions are the present. So what am I right now? I'm a guy in Colorado trying to share my knowledge of pain and communication and why it's so important to me to a group of whoever will listen. And if you think about your clients or even yourself in persistent pain, what you are is always the hardest thing to accept. That you are not currently able to tolerate running 15 miles, that you are not currently able to tolerate working out the way that you want to. And by struggling with acceptance and by struggling with the what, I think that's what keeps a lot of us and our clients spinning their wheels and searching for quick fixes. So one of the most important pieces of communication is sharing prognosis, helping people realize that they are okay and they will be okay. And how long will that actually take? That has been a big shift of mine in my practice, rather than trying to get people to commit to or work on fixing themselves in one moment. They didn't get to me usually in one moment. It was an accumulation of time. So it's not going to be a quick reversal. And I think intuitively we all understand that, but struggling with that what question and getting clients to accept what is currently happening is a big key to our rehab and our movement practices that I think sometimes goes a little bit underutilized. Now, I want to take a look at this picture. And this is a picture I typically share in a lot of these courses. And to me, this summarizes what medicine used to be. There used to be genuine concern between people. There used to be compassion. There used to be problem solving. There used to be teamwork. And now in this picture of a physician coming to care for a sick child, you can see that he's almost welcomed into this home as a friend. He has tea or maybe coffee. He's shining the light directly at the child to help him focus on her. He has a look of care, concern. The father in the background almost stepping away, extending trust to this person to take care of the thing that he values most. Now, if we look at this picture, it's actually called The Doctor, painted in 1891. And we look at this picture of a healthcare interaction drawn by a child. What's different about these interactions? We have a family here. We have a child on the table. We have a doctor, but we have a doctor also facing the other way, typing away on their keyboard, not engaging with the family, not communicating concern or empathy or compassion. And if we look in the background, here's the neighborhood which this family had to come to see this clinician. And maybe that's something that we don't give enough credit to our clients for doing as well. These are clients who are hurt. These are clients who are in pain, coming away from what makes them feel safe, their homes, into a strange environment, potentially meeting people or interacting with people they've never met before, and extending trust. Or maybe from our perspective, they should be grateful. They should be understanding. They should listen to us. They should pay attention. They should do everything that we tell them to do. But why are we earning that right with our clients if this is now the perception of many, many healthcare interactions? And I'll put my hand up in the air that I've been guilty of this. And seeing a picture like this immediately made me reflect and change how I take notes now in my clinic. For first-time interactions, it's a pen and paper, and I'm trying to make as much eye contact with my client at that session. I'll typically even sit lower than them. This is not something you guys have to do, but it was sort of reported that if we hold our clients up a little bit higher, they may be more comfortable from an empowerment standpoint. So I actually have them sit on the table. I sit on my chair as low as it can go, or as long as I can comfortably make it go. And I look up to them. And they're sort of looking down on me as I'm trying to help them and trying to understand them. That's how I do first interactions now. Second, third interactions, yes, I'm bringing my laptop out with me into the gym, and I'm making sure that I'm commenting or writing notes about the person as we are experiencing the session together. That way, I don't have to memorize 15 or 20 different client interactions a day, and I'm capturing the emotion, I'm capturing their story right off the bat. And now I actually even say, excuse me, I'm going to write that down because I think that's really important for us to remember, and I'd like to hold on to this for future sessions. And clients really appreciate that. They appreciate being heard. Other things that we are up against now that maybe we weren't up against in 1891: drugs, pharmaceuticals, insurance companies, Big Brother, kind of overarching the control of the healthcare system. And this is also something that we need to take into account. The stats on pain are always mind-blowing to me. And no matter how many times I share them or say them, they still cause me to pause. So pain costs $635 billion a year in the US. 1.5 billion people suffer from chronic pain. 1.5 billion. We're now, I think, a little over 7 billion people, or we've just maybe eclipsed 8 billion. It's a lot of people in persistent pain. Here's another one. The US makes up 4% of the world's population, and yet we are responsible for 80% of its opioid use. These are startling numbers. Maybe even more startling than that is the lack of empathy and compassion that continues to remain in the healthcare system. For instance, only 53% of patients, according to one study, and 58% of the medical professionals in the system state that they receive or provide enough compassionate care. Now think about that. Think about that painting. To me, that exemplifies compassion. That's where we started. That's what our foundation was. Understanding the person in front of us and then making decisions. The healthcare system today, I think, is forcing us to make decisions about people, or dichotomize them, or put them into groups before we even meet them, just maybe based on their diagnosis or the prescription that they come in with from the doctor. That's not fair. What made me sort of realize I had to change my ways? It was one client in particular. Before this client, I was still writing notes as fast as I can, looking down on my laptop. I was not as engaged with clients outside of the clinic. I wasn't providing them any type of social support. The only time I would be interacting with them would be while they were with me, either on the treatment table or doing a few exercises once or twice a week. And just like the pigeon, I was getting outcomes every once in a while. And because I got those outcomes every once in a while, I didn't think of changing my ways until a client handed me a card, which I will never forget. And in this card, she wrote how great it was to be with me as a provider during her care, And initially I was kind of taken aback by it. She was young. She would come in with her boyfriend. She was recovering from a surgery. We got along very well, but she was very anxious in the beginning of her sessions. So much so that she would be shaking on the table anytime that I would go to touch her. Our sessions would normally be filled with tears, frustration, her not making much progress week to week, but she stuck with me. And I didn't really know why at the time. But when I read this card, she said that I was the only person of everyone she's met. And at that time, she'd been to 5 or 6 different PTs during the course of her surgical rehabilitation that actually took the time to listen to her. And I didn't even know I was doing that. That took the time to make her boyfriend come into treatment sessions. And I did that because I just didn't even know what to do. Like I said, we were frustrated on both sides. So I started to ask her, would it be okay if your boyfriend does manual therapy on you instead of me? And if I guide his hands or teach him how to do 1 or 2 things? So in the card, she stated the reason why she was so anxious, she was so concerned, she was so fearful, was that she had been sexually abused as a child. And she had been in a physical abusive relationship with a previous boyfriend before she met this one. So I didn't ask about why she was scared. I didn't ask about her past. I didn't ask about her beliefs. I didn't acknowledge her fear. I was just worried about getting her knee straight and her knee bent and her quad functioning, because if I didn't do that, the doctor probably wasn't going to send me more clients. And being a part of a clinic, it was important as a referral source. And I remember reading that card and basically breaking down and crying with her and her boyfriend. And I apologized and I said, I had no idea. And I feel like I failed you. But through that failure of me not realizing this and the importance of these stories for our clients and how much I could have probably helped her much sooner, helped myself too. Let's not forget that this is a two-way street. So if you're a client or you're a patient watching this or you're a professional watching this, this is a two-way street. Our frustrations as clients bleed into our sessions. Our clients' frustrations bleed into our decision-making. But if we can better understand each other, we can formulate a team. Now, we've seen the evidence-based pillars, right? And if you haven't seen evidence-based pillars or you're not understanding of them, maybe, like I said, you're a client. As clinicians, evidence-based care usually means 3 things or 3 overarching themes. And they've been called pillars, or we've had interlocking circles as healthcare professionals explain the evidence-based system. But essentially they are the totality of evidence, clinical experience, and patient preferences and beliefs. And all these circles or pillars are thought to be even. And I want to credit Eric Mira, who's a physical therapist, for introducing the concept of a funnel system rather than a pillar system. The only difference that I take with the funnel system is I start this funnel sort of like upside down with the person in front of me. Once I understand the person in front of me, their beliefs, their expectations, then I can look at the evidence that will help guide me in making the best decisions. But as I start to interact those two, I need to use my experiences as a clinician to decide what is right. Just because a new research article came out about low back pain, about ankle pain, about shoulder pain, that states this is the best way to treat someone, does not mean it is the only way to treat someone. And in these large cohorts of people that we have in these research studies, if I had 100 people and my exercise prescription or my treatment worked for 80 people with pain, that would be amazing. And every single person would want that treatment, and every clinician would want to administer that treatment. Here's the problem. It didn't help 20 people in my study. Where does that leave them? And that's the mindset I really want us to have as both clinicians and clients. This idea of teamwork, this idea of starting with the person, this idea of having multiple treatment options or multiple routes, not even within a month or 2-month period, but even within a session, because things change moment to moment. And that's the crazy thing about pain. There is no pattern. There is no sort of quote unquote rhyme or reason for pain many of the times. And maybe one of the things about pain that's so confusing is that it's a subjective experience. There is no way to objectively measure pain. I can't see it in my clients, although maybe we can make assumptions based on their face, their breathing, right, their story, but I can't experience what they experience. And that's something that is really important to hold on to. We have to take clients for their word with what they are experiencing. We have to make them feel safe. But maybe we also have to agree on what pain is. So think about that. What is pain? What is your definition of pain? Write it down. Think about it. Consider it. Because there is a definition of pain from the International Association of the Study of Pain. I will read you the definition. An unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Actual or potential tissue damage. Sensory and emotional experience. I think too many of our practices target the sensory experience with pain. That's why any sort of manual therapy can work. That's why people like foam rolling. That's why people like massage guns. That's why people like tape and cupping and needling and everything else, because it's modulating a sensation. But what is it doing to train or teach new emotions? What is it doing to help a person feel safe? Or are these things just making people feel different? So if we have this evidence-based model of a funnel, the thing I've started looking at from a biopsychosocial component is these biopsychosocial components of a person and their environment are like the lenses we see when we go through the eye doctor. So if you've ever been to the eye doctor, right, they place that big device on you and they're flipping the lenses, 1 or 2, they're sliding things around, right? And eventually these blurry pictures that are in front of us become more and more clear. The pictures themselves don't change, just our perception of these pictures. So if we look at this lens here as biological, this is tissue, muscle, joint, right? All of the hard stuff that maybe we blame on pain a little bit too often. Maybe this lens that's out of focus is the psychological components of what people are going through. The anxiety, the fear, the worries, the frustrations, the depressions. And then here's the social lens, maybe still a little skewed off to the side. And the social lens is, well, what's your relationships like at home? What's your relationship with pain? Who is there to support you? What is your job, right? And if we look through this lens from an individual person, this shapes our world. But our world, filtered through these lenses, also shapes us as a person. So it's sort of a through the looking glass that my external environment is going to be filtered through these lenses and create a lot of my emotions and beliefs as a person. And ipso facto, my emotions, beliefs, and internal environment filtered through these lenses is going to shape how I interact in my world. And the more we can line up these lenses, the clearer the person becomes in front of us, the clearer their environment and how we can get them to interact in it. And it's okay if you don't specialize in these lenses, right? Because sometimes I'm going through the flip with the eye doctor and he's like 1 or 2. And I'm like, it's about the same, right? Well, that's the way that I can flip it as a provider. So if you're not seeing progress with your provider, if you're frustrated by outcomes, don't keep trying the same thing. Bring someone else on board. I love working with strength coaches. I love working with yoga teachers and Pilates instructors because they share such a different lens of all of these things. And they really help my clients, especially when I've taught them everything that I can about their pain. We've discussed their emotions. We've discussed exercise prescription, but I'm missing the big factor of getting them back into the environment that they want to be. And the environment they want to be is their Pilates class, their yoga class, their strength class, their running club. So I have to bring these people involved into that person's lens, if you will, if we're going to bring them into focus. The other issue I think with pain is that it's often viewed as scary. That's a sign of damage, a sign of foreboding. Bad things are going to happen if I still have pain or work through pain. But what if we can start to rephrase this idea that pain is actually there to protect us? Now, it could be overprotecting us, that's for sure, right? I don't need Superman to come in to help me with my groceries. That's overprotection. That's not a good use of Superman's time. I need Superman to save me from the burning building or the things that are kind of falling around apart or the ultra bad supervillain. Like that's a better job for Superman. He doesn't need to be there with me every waking moment because I'm not under constant threat. But for our patients in pain, that's how their body perceives themselves, under constant threat. Therefore, they require constant protection. So regardless of our top-down or bottom-up approaches that we can talk about with pain, we won't go into a great detail of them today. I want us to just keep in mind that no matter what, pain is always a perception of threat that's perceived by our brains. Just take that into account and reflect on that as a clinician, reflect on that as a client, that maybe I'm not always in constant danger, but if I perceive that I am in danger, or if I remain on high alert all the time, that could be what's contributing to my sensations. And this all happens relatively fast. We are good learners as humans. Think about any class you've ever taken. Think about school. Think about your job. What has gotten you better at all of those things? Showing up and being consistent. Hearing a message over and over and over again. Practicing something over and over and over again. The same way we learn anything is the same way we learn everything. Now, there's usually 3 different types of learning processes that occur. Ones can happen at a neural level or like a nerve to nerve level. And as nerves get better at talking to each other, you can think about putting on noise canceling headphones and just flipping the on and off switch for your noise cancellation. As nerves get better at forming circuits, just flip that noise cancellation on and they're able to drown out everything else. The other one is associative. So we might associate a behavior or sound or signal or environment with our pain. We can also think of Pavlov and his dogs here. That's usually the common thing that pops up. And then we can get so good at association and these neural drives that we can now actually predict it. Oh, I don't do that anymore because I know it gives me pain. And now I've changed the way that I'm interacting in my environment. I've changed the way that I move. I don't go to the gym anymore. I gave up on physical therapy. I gave up on chiropractic because those things just didn't work. So those are the 3 ways we can learn. But here's the best thing. Our perceptions can shift instantly, which is awesome. So look at this picture. If you see squares or circles, right? And I assure you that they're both there. Do you see squares or do you see circles? And when I bring up this picture, most of the time, people are only seeing squares. And that's because we traditionally focus on the horizon and this sort of east and west idea when we're looking at pictures. But if we reorient, and I just circle these vertical lines here for you, and you focus on that red circle, you should start to be able to see a different lens of viewing the picture. For some of us, we might be able to see the squares and the circles almost at the same time. For a lot of us, we'll see one, we blink or we shift perception, and then we lose the other one. So this is what it's like for people in pain. I can shift your perception, but it doesn't mean it's going to stick. And that's what we have to remind ourselves, and that's what we have to remind our clients. Because our clients and us are programmed to always see a snake, even if it is a stick. And we have to think about why that would be from an evolutionary standpoint. If we were looking for survival and keeping ourselves safe, it would be much better for our nervous systems to think about everything as a snake rather than everything as a stick and be wrong one time and thus risk death or serious injury. So the reason why we are programmed to protect is the same reason why we've been able to thrive and survive on this planet. Difference is, though, we're not always under this constant danger or threat anymore. We're not wandering around the wilderness. We're not in unsafe environments. And this is very abnormal for our predetermined central nervous system that's always sort of on high alert. So we have to get people to realize that there are sticks still remaining in the rehab and movement world. And even if you are perceiving them as a threat, you are still safe to move with them, around them, or through them. So the biggest thing I think we want to do as healthcare providers is just rule out red flags. There's a whole bunch of ways to do this. Google red flags, memorize them. If you're a client, don't Google red flags because it'll just make you concerned. Okay. And then everyone's always going to have one red flag, and then they get worried and then talk to everybody about it and then get more unnecessary tests. But if you're talking to your clinician and you're like, hey, how do you know I'm okay? How do you know I'm okay to be here? Well, we can answer those questions because you passed our red flag screen. You're here. Your doctor sent you here. Your doctor gave you medication. Your doctor didn't give you surgery right off the bat. Your doctor said, try this. Even if it was for 6 or 8 weeks, they still said, try it. It might work. It might help shift your perceptions. So we have all these things working for us. The other thing that we have to think about is that people just sometimes take a long time to make decisions. We can be stuck in pre-contemplation, which is essentially no intention to change behavior. Hey, I don't work out, I don't exercise, I have pain, and you know what? My life is fine. So it's not my role as a physical therapist to change your lifestyle if you have no intention of doing so. As you contemplate change, you maybe are thinking about it. Hey, my wife has been getting on me, my husband's been getting on me, I probably should work out a little bit more, I probably should lose weight, but I just don't know how because I'm in pain. Or every time I do try to do it, I have pain happen all over again and it unmotivates me. Then we have preparation, which is starting and stopping. I get a little bit of consistency, maybe a week or two, and then life gets in the way, and then I don't prioritize it, so I stop doing it. And then we have action, which is change that lasts for less than 6 months, and then maintenance, which is change that lasts for more than 6 months. But to get to action and to get to maintenance, as we roll through those other stages that we just talked about, those other stages can last a month or 2 or more, person to person. And it's not linear. You might go into pre-contemplation, go into contemplation, and then go back to pre-contemplation. So it does not necessarily go step 1, step 2, step 3. Nothing does. So we can fall down on the steps or we can work our way up. But this is important for us to realize as healthcare providers. Because if we think about the prescription for exercise, when are people going to get the benefit from exercise, or who's going to get the most benefit? The people who are going to get the most benefit are the ones who don't do it. So if we can convince people that even going to the gym 1 day a week, if going for a walk 5 or 10 minutes a day is a little bit more than what they're doing right now, they are going to get immense benefits physically, psychologically, emotionally, you name it. It's a lot harder to keep people working out when they're stuck, when they're not seeing the change in strength or progression. But normally, a lot of us are going to say, Do yoga, Pilates, strength work, running, whatever, and see how you feel after 3 months, right? 12 weeks. Do it consistently. Then you should start to see improvement. But what about education? What's the prescription for education, right? Our clients have jobs, kids, families, right? They can't come in for 2-hour lectures. They can't come in multiple days a week. So if we can dose as little as 10 to 15-minute sessions, 1 to 2 times a week, that can be beneficial. How can we do that with our practice? Take the time to listen. Take the time to educate. Make that just as important as your manual therapy. Make that just as important as your exercise selection. There's a quote I always am reminded of. It takes 7 times for a person to hear your message to understand it. Think about your clients after 2 weeks, 3 weeks, 4 weeks. If you're seeing them once or twice, the conversations that you have over and over again, these are normal. Don't get frustrated. Welcome the questions. Give yourself a minimum of 7 times to hear it, 7 times to explain it, 7 times to understand it. And if you're starting out, I'm going to give you 3 keys on what you want to portray to your clients when it comes to talking about pain. And then we'll talk about a couple of stories that might help us drive home these analogies, and then we're done. The 3 keys. Pain protects us and promotes healing. Persistent pain overprotects us and prevents recovery. And many, many factors influence pain. And the wonderful thing about having so many factors influencing pain is that there's so many ways to deal and cope with it. But we usually have to tie this to a story. We have to give it an analogy, a way of thinking. And how powerful is story? Well, I haven't heard the story of the 3 little pigs. Maybe I did tell it to Avery. So I'm going to say it's been about 10 years. But before Avery, it was probably 20 years. And I remember the story of the 3 little pigs. I remember the story of Little Red Riding Hood. I remember the story in my favorite movie, even though I don't watch that movie. So story connects us. It forms ideas for us. And if we can utilize story and utilize questions, I think that can really help us drive home these messages that we want with our clients. So I'm going to share some stories with you in a second, but I'm also going to give you 2 or 3 questions that I want you to start to potentially implement with your clients as soon as you can. These are open-ended questions. We don't want yes or no. We don't want dichotomy. We want people to be able to express themselves and share their perceptions and their beliefs. So here's a couple of ones that I use regularly. Has anyone explained to you why you hurt? Would you like to know more about your pain and maybe why it's not getting better? Do you have any concerns other than your chief complaints? And a chief complaint is I have shoulder pain. My concern is that I'll never be able to CrossFit again. My concern is that I'll never be able to play with my grandkids. These are different conversations, but we want to invite story. We want to invite open-ended discussion. So if we can use those questions to engage our story, to engage our client, once they give us permission, then they'll be more receptive. So we're looking for that permission to share, not making it a mandated thing of us biting our tongue and clenching our fists like, oh, I can't wait to explain pain to this person. I can't wait to share these analogies that I learned. No, maybe you get to those analogies on visit 2, maybe visit 3. Maybe you don't ever get a chance to do that because the client didn't need them. Once you're given permission to share, then share. But that permission is key to get clients engaged and to actually have them receive the message. So how can we share some examples of pain and story? One of them is a smoke detector. Now, we love smoke detectors. They keep us safe. However, smoke detectors can also be super annoying when you are cooking. They sense the same signals of smoke. They perceive danger. And even though we aren't in danger, we are in the comfort of our kitchen, cooking maybe our favorite meal, the smoke alarm goes off, right? And it blares and it blares and it blares. Now we deal with that because when we are asleep or maybe not at home, to alert others in the area or to wake ourselves up and make ourselves alert of danger, we want these drivers. We don't want to shut them off. We're not going to take a hammer to our fire alarms. We're not going to take a hammer to our pain sensors. We don't want to have our pain sensors turn off forever because that wouldn't be beneficial for our survival. What we want to do is understand the signal and the context that we are in. Understand when there is danger, understand when we need to maybe modify our behavior and our environment, and then understand some coping strategies on what to do about it when things need to be done. So when we're cooking, these smoke alarms create a lot of noise, but we can still cook. That's what we want to talk about when it comes to pain and movement and positive coping strategies. I know you're getting some alarms here, but you are safe. You are cooking right now. If we see these flags or sensations come up when you're at rest, we'll still learn something that maybe we weren't able to tolerate as much as we did today, that maybe we pushed too hard. But this is an art. And guess what? Even when we get these negative outcomes, it's a learning experience for both of us, because now we know what you can tolerate, what you're better at tolerating, and then we can really give you a plan for success. The other idea is distraction. Bob Marley has a quote: "When the music starts, the pain stops." So where are you doing your activities? Are you able to focus on mindfulness? Can you do movements in a specific room? Can you do movements with someone? Can you call someone for support? Can you play your favorite song? Can you hum your favorite song? Can you count backwards from 30? Can you suck on a lemon? There are so many things that we can use for distraction. But even when we're able to distract ourselves from a signal of pain, it should maybe give us more of this comfort that maybe there is not something too concerningly wrong. Because if my knee really needed to be replaced, if my hip really needed to be replaced, if I really needed to get that lumbar fusion or neck fusion, well, it shouldn't matter what I do. No amount of distraction is going to improve my function. No amount of distraction is going to get me to feel better, sleep better at night. So we're lucky for those things because now we know, hey, maybe I would respond to something more invasive. But geez, whenever I listen to my favorite song, or I foam roll a little bit, or after I talk to my spouse, or after I play with my kids, I feel better. What gives? We're de-threatening our bodies, and therefore that pain signal gets a little bit better. The only other one that pops up is, why am I having pain over here, over here, over here, over here, if the X-ray or the MRI says my issue is right here, right? Now I'm feeling pain in my neck, pain in my side, pain in my low back, pain in my knee. And the example I want us to remember is just think of your noisy neighbor, the one that's throwing the party at 2 a.m., has nothing to do with you, but the sound and the amplification of the signal from one area is going to cause amplification of signal everywhere else. And then before you know it, it's not just one apartment making noise, it's all the apartments making noise, because now these apartments are angry at the party is still raging. Now we have maybe police officers or superintendents coming up to check out, banging on the door, right? So this is the analogy I share for referring of pain or referral of symptoms. Often that can confuse clients and not make a lot of sense. But if we realize we're an interconnected unit, like this apartment building, well, then it's going to make a little bit more sense. So if we can get our minds to focus down on the signal, pay attention to maybe where it's coming from, know that the other areas are just being distracted, we can keep our mindset, we can keep our focus on the task at hand. I'm going to let you listen to one story. It's about 2 minutes long, and then we'll wrap up. But I really think that my client here really exemplifies all the points that we were trying to make today and sums them up nicely from her perspective, not from mine. So I'm going to let her take it away.
What beyond your clinical expertise or any physical therapist's clinical expertise has allowed me to feel progress, to experience progress, to actually engage in healing in a way that is useful for me and gets me where I want to be. So I come at this, as you know, as a professional executive and leadership coach. So a lot of my thinking around this is shaped by my own training and my own belief and my own learning that, ironically, less is more. And that, as deeply clinically and technically trained as we might all be, what I need from you is for you to be there with me, to listen to me, to see me as a whole person, not just as a low back injury or structural weakness or whatever is happening. Because that's not how I experience my problem. Like, I don't think of myself as a body part. I don't think of myself in technical terms like that. I think of myself as a human, as a mom, as a wife, as a person who's having a hard time and who's not living the way she wants to live because of her perception of the role of pain in her life. And so what has been helpful in our work together is that you see that and we are able to engage in that, that the presence and the trust in the relationship is really primary. And it comes up in the kinds of questions you ask, right? Which are not only about like measure of pain or something, a range of motion, but around experience. It comes up in patience and you making time and space for us to talk about how pain is part of my life, like it's how it shaped what I do and don't do. And you challenge some of the beliefs that I allow to settle into my brain around how much my life's going to be governed by how I feel and how I relate to the pain itself, to what degree the pain creates anxiety. I have negative thoughts about it. I limit myself. Every time I've gone to a physical therapist before, they've whipped out that chart and they look at the body on the piece of paper and they circle things and highlight things. And meanwhile, I'm sitting right in front of them, right? Like, I'm the body, I'm the person, I'm the soul, I'm the human who needs attention. And especially with something like what I have, which is just this chronic experience of pain, some of what I just need is to be heard and to be honored and to be understood, even if you can't understand it, to be respected as someone who is having an experience, not to be told my experience is imaginary or it's time to get over it. It is time to get over it, but what makes the difference is having someone on the other side of Zoom who can hold the space, right? That's what we talk about in coaching. We're just holding space for me to go through my process, and for you not to look at the chart, but to look at me.
So that's going to wrap it up. I want to thank you all, whether you're watching now, later on, next week, for taking this 50 or 60 minutes or so out of your day. I hope it was valuable. I hope it made you reflect on some things as a clinician or even as a client. And I just want to let you know that there will be more to come. My hope is to reopen the little Strength in Motion school for you all, taking bite-sized courses, 2 to 4 hours in duration, maybe a little bit longer, maybe a little bit less, but focusing on specific ideas on communication, specific areas of the body, and how can we tie all of the pieces that we just broadly introduced today into more of a narrow, focused view that you can really use as both a person and a clinician. So thank you again. Be on the lookout. Would really appreciate feedback on where you want to dive into, what you want to challenge, what you want more resources for. I'll be here. Joe@strengthinmotionpt.com is my email address. Strength in Motion PT is the Instagram handle. Follow along, give us ideas, and we look forward to seeing you again in the future. Have a wonderful day.